and thanks everyone for joining. Over the next several minutes, I'll discuss head and neck cancer, particularly recurrent metastatic disease, and the current standard of care treatment approaches for this disease, with particular focus on challenges and opportunities. Next slide. Here are my disclosures. Next slide. So we'll start with a patient case. This is a patient of mine, a 68-year-old woman who developed a recurrent head and neck cancer. She was initially diagnosed back in 2016 when she was diagnosed with a local regionally advanced supraglottic cancer that was staged as a T3N3 tumor. She received at that time induction chemotherapy followed by definitive concurrent chemoradiation, and after which also underwent a salvage neck dissection, a surgery, which demonstrated a pathologic complete response at that time. She did well for a number of years, but unfortunately, when I met her in 2020, she had developed an enlarging right-sided neck mass with biopsy demonstrating at that time recurrent squamous cell carcinoma, and PD-L1 testing, the biomarker that we use for immunotherapy, was completely negative. Her combined positive score was 0. You can appreciate in some of these PET scan images here that this was very extensive local regionally recurrent disease, including invasion of the supraclavicular space. And as I'm sure you can imagine, this has not only was a very painful tumor at the time that she presented, but had major impacts also on swallowing and on function, and of course, as you can imagine, on quality of life. And so the question becomes, in this particular setting, what is the best treatment approach? It was determined by our surgeons that this was non-amenable to salvage surgery, given the extent of disease. And so immunotherapy with chemotherapy would be the standard palliative treatment approach in this treatment setting. Although with PD-L1 negative disease, the opportunity for PD-1 alone, or the addition of that to standard approach, remains quite reserved. Next slide. So we actually enrolled this patient on the 1100 study, which involved injection of her right-sided recurrent tumor with NBTXR3. And you can actually appreciate the post-injection imaging on the top there on the CT scan, where you see in the area of the very large tumor, the radio-opaque nanoparticles that we can actually see on the CT scan. This was followed by SBRT radiation as well as immunotherapy. And on her follow-up scan, which you can see on the bottom slide, you can appreciate now that while you can still see the clear nanoparticles quite apparent on that CT scan, it actually looks even more clear than on the top slide after the initial injection, because we see regression of the tumor around the nanoparticle. As you can imagine, with regression of her tumor, this also resulted in improvement in her pain, in a number of her symptoms. And fortunately for her, she completed 2 years of immunotherapy without disease progression. And again, with PD-L1 negative disease, this would be quite unusual and unexpected with pembrolizumab alone. Next slide. So when we think about local regionally advanced disease, which we see as the majority of our patients, we know that this is quite a heterogeneous disease that can arise at multiple places within the head and neck cancer space. As you can see on the right, of course, on the oral pharynx, we see tumors that are HPV associated, which is a unique clinical and biological subset with very good prognosis. However, we still see a substantial proportion of patients with HPV negative head and neck tumors that can arise either in the oral pharynx or at other subsites within the head and neck cancer space. And even with our multimodality treatment approaches incorporating chemoradiation or surgery, survival remains quite poor, despite the fact that we try to cure these patients. We only manage to cure about half of these patients. Next slide. So here you can see the survival outcomes by HPV status. You can see in the top curve that HPV-associated oropharyngeal cancers are actually associated with quite good prognosis. And actually, in these disease types, much of the clinical trials and research is focused on selecting patients for de-intensified treatment and seeing who we can give less toxic treatment to maintain good survival outcomes while reducing treatment-related toxicity. On the other hand, as you can see in the lower survival curve, HPV negative tumors, which again are largely carcinogen-induced diseases attributable to tobacco and alcohol and other carcinogens, that survival remains quite poor. Even in the curative intent setting, we only manage to cure about half of these patients, with a substantial proportion developing recurrent or metastatic disease. Next slide. So how do we think about the standard of care in the local regionally advanced setting? Well, for the oral cavity patients, the first thing we think about in this setting is whether patients are amenable to surgery. Most of these patients will go to surgery, followed by adjuvant radiation or adjuvant chemoradiation based on pathologic risk. In the oral pharynx, these are patients that can have either HPV positive or HPV negative disease. Treatment approaches can include either definitive chemoradiation-based approaches, or in select very early stage patients, minimally invasive surgery such as TORS, followed by adjuvant radiation or adjuvant chemoradiation. In tumors of the larynx, most of these patients will be treated with an organ preservation approach with definitive chemoradiation versus a select subset of patients that are not good candidates for organ preservation that will typically go to laryngectomy up front. The nasopharynx is a unique biological subset of head and neck cancer, often associated with Epstein-Barr virus, EBV. In this disease, this is really treated in a distinct way with chemoradiation, often with the addition of induction chemotherapy and/or adjuvant chemotherapy, and immunotherapy has an evolving role in this setting. And then you can see here the standard radiation doses in either definitive setting or in the adjuvant setting, either alone or in combination with chemotherapy. And the standard chemotherapy for eligible patients is cisplatin. Next slide. Unfortunately, a substantial proportion of patients, particularly with non-HPV-associated disease or with high-risk HPV-associated disease, will develop recurrent or metastatic patients. And this is associated with very poor survival. We see patients develop either local regionally recurrent disease or distant metastatic disease, or a combination of both of these treatments. And median survival in this setting is quite poor, even with novel immunotherapeutic approaches, with median survival of only 11 to 13 months. Next slide. So our current standard approach in the recurrent metastatic setting was built on the KEYNOTE-048 study, which took patients in the frontline recurrent metastatic setting and randomized them to 2 experimental arms, either pembrolizumab alone or pembrolizumab with chemotherapy, versus the standard of care prior to that, the chemotherapy with cetuximab or the extreme regimen. Next slide. And the results of this study demonstrated that for all comers, pembrolizumab with chemotherapy, as you can see on the right, improved survival compared with the extreme regimen. However, I would like to highlight that at long-term follow-up, only 16 to 19% of these patients remain alive. So even with chemoimmunotherapy approaches, long-term survival remains quite poor. Next slide. And in the PD-L1 enriched population with PD-L1 combined positive score of 1 or greater, we saw a survival advantage of both the pembrolizumab monotherapy arm, which you can see on the left, as well as the pembro plus chemotherapy arm, which you can see on the right. So both experimental arms were superior. However, again, long-term survivors remain quite poor, only 15 to 18% of patients. Next slide. And particularly in patients with PD-L1 negative patients, we see really no additional benefit to the addition of immunotherapy compared with chemocetuximab when you look at the PD-L1 subsets. And in this population, this really highlights that there remains a particularly unmet need, particularly in PD-L1 negative patients, similar to the patient that I presented who was enrolled on the 1100 study. Next slide. So the standard of care treatment approach in the recurrent metastatic setting, in the frontline treatment setting for PD-L1 positive with a combined positive score of 1 or greater, standard approaches remain either pembrolizumab alone or with chemotherapy. For PD-L1 negative patients with CPS of less than 1, similar to the patient that I presented, standard approaches are either pembro plus chemo or chemotherapy with cetuximab. The chemotherapy backbone can be either platinum 5-FU, which was the one evaluated in the 048 study, although platinum taxane is a commonly utilized and now studied platinum doublet to be used in the frontline setting. And then subsequent line treatment options are really cetuximab with or without chemotherapy, or pembrolizumab with or without chemotherapy, depending on what patients received in the frontline. With survival outcomes quite poor in this setting, really on a number in terms of median survival of months. And radiation largely has a palliative role. Next slide. And so this provides opportunities to build on these current results and improve outcomes in terms of particularly harnessing the vulnerabilities of the key hallmarks of cancer and head and neck cancer in terms of avoiding immune destruction, building on immune activating monoclonal antibodies such as PD-1 or PD-L1 immune targeted therapies, which have an established role, and building on that, but also in resisting cell death and in radio enhancement. This is another space which we know is quite important for local regionally advanced head and neck cancer and recurrent metastatic head and neck tumors, which tend to be more radio resistant, in which there's opportunity to build on this hallmark of cancer vulnerability. Next slide. And so where are the biggest unmet needs? Well, in the local regionally recurrent disease, this is a particular space where there's a true unmet need, not only because of the very poor survival outcomes, but also because of the substantial morbidity associated with local regionally recurrent disease. And I actually pulled here on the right side the 048 data. And if you look at the patients that had recurrent disease alone, the plots actually cross one, suggesting that this is really an area of need where either pembro or pembro plus chemo, we need more improved therapies, particularly for this particularly recurrent subset of head and neck cancer patients. Novel combinations with pembrolizumab and PD-L1 positive patients in the frontline setting remains an important area of interest, as well as improved treatments after refractory disease to both immunotherapy and platinum-based chemotherapy. And in particular, harnessing multimodality treatment approaches that incorporate both radiation and other specialties, even in the recurrent metastatic head and neck cancer setting, remains of great interest. Next slide. So I hope this gives a flavor of the fact that despite curative intent treatment, most or many patients, I should say, will develop recurrent disease, that survival is quite poor for these patients, and that patients with local regionally recurrent disease demonstrates a unique challenge because of the substantial morbidity as well as negative impact on function and quality of life of this disease. And there's opportunities to improve outcomes in this patient population.